evening, everybody. This is one of the presentations we are doing through SLACD. Today's topic is about neonatal brachial plexus palsy. This is especially for professionals because I chose this topic because I see a lot of cases, and sometimes I see that the awareness among the parents and the professionals are very low. So I thought it was a good topic to talk about. I will talk the medical part of it, and after me, our occupational therapist, Ms. Veronica Lakmali, will talk to you about the therapeutic aspect of brachial plexus palsy management. So, when we talk of neonatal brachial plexus palsy, so its incidence is about 4.4 to 4 per thousand live births. It's caused by stretching of nerves of brachial plexus during the process of birth. So when I go to the pictures, you will understand. Its incidence may be reducing. They thought that it may be reducing because the cesarean section rate is going up, and labor induction and decreasing incidence of macrosomia. The prenatal monitoring systems are good, and access to widespread better obstetric care. This is not a good thing to happen, but the good thing about it is 10 to 30% only are left with residual neurological deficit. So the risk factors for brachial plexus injury are gestational diabetes, macrosomia, shoulder dystocia, prolonged labor, instrumental delivery, breech delivery, and fetal distress resulting hypotonia. So I will skip the slide and go to a picture for your understanding. So the mechanism of how it happens. When the child descends through the birth canal, if the child is big and if there's shoulder dystocia and all that, so his neck is stretched, shoulder and the head is moving relatively away from each other, and the brachial plexus can thus be stretched, and that is the mechanism of injury. So we are going to talk about that in detail. So if we recap our memories about the brachial plexus, it is formed of cervical C5 to C8 and first thoracic nerve roots. They connect to form roots of the brachial plexus, and then they divide into dorsal and ventral rami, and ventral rami get together to form the plexus from C5 to T1. Then they form, after the roots, it forms trunks, and then divisions and cords. So upper trunk is formed by the C5 and C6 roots, as you can see in the picture. C7 continues almost alone as the middle trunk, and lower trunk is formed of C8 and T1. So this anatomy knowledge about the anatomy helps you to understand how these clinically present. So this then divides into anterior and posterior divisions, and then divisions combined to form cords, which are not clinically important. The trunk level, understanding the level of the trunks and the distribution of the trunks, the root values are of utmost importance to clinically diagnose and classify brachial plexus injuries. So C5 and C6 are the upper trunk, C7 continues as the middle trunk, and C8 and T1 as the lower trunk. So in the root level, connective tissue covering is absent. So when you talk of mechanisms of injury, I showed you how it is stretched, and Then there are preganglionic and postganglionic nerves. Preganglionic injuries occur proximal to dorsal root ganglia. So dorsal root ganglia are present in when the nerves come out. In the dorsal root, there's a sensory ganglion. So in preganglionic injuries, the nerve root evolves even before the dorsal root ganglion. So it involves C8 and T1. This is normally this is called happens in clunky spore paralysis, where you get abduction injuries, hyperabduction injuries during breech deliveries. Where you see Erb's palsy or more common form of brachial plexus injury, it happens in the upper trunk level. So it is usually postganglionic. When it happens, preganglionic injuries cause a poor prognosis and cannot be repaired by direct surgery. So postganglionic injuries are more common and of better prognosis, could be further classified by Shedden-Sunderland classification. So these are pictures for you to understand how the injuries occur. So you can see the plexus is stretched in the picture when the neck is stretched. And there are vulnerable areas where you get most common injuries. So this picture shows you the mechanisms of injuries. Avulsed C5 nerve root, ruptured C6 nerve root, stretched C7 nerve root. So this is a typical brachial plexus injury. So you get the most severe injuries in the upper trunks, less severe injuries in the lower trunk. So this is just a picture to demonstrate, but I will go into more scientific classifications lower down in the other slide. So this is the Shedden-Sunderland classification, which scientifically explain the levels of nerve injury. The first level of injury is just neuropraxia, where there's only a conduction block. It's your first picture. There's only a conduction block, and your endoneurium, perineurium, and epineurium all are intact. So the nerve is temporarily affected and will recover quickly. And the second, third, and fourth levels of injuries are due to axonotemesis. Your axon of the nerves are discontinued. That also is divided into three: axon and the endoneural disruption. And then in the third level, axon, endoneural, and perineural rupture, all fascicles are destroyed. But the nerve sheath, nerve trunk is intact. But again, these black dots represent Valerian degeneration. Nerves start degenerating from the point of injury. But as you can see, the direction of the nerve, the sheath, the pathway is intact, so the nerve can grow back. After a while, the nerve can grow back in the same pathway and recover. There's a potential to recover. But in neurotemesis, your whole of your nerve is disrupted. The nerve sheath and the nerve trunk is gone, and these nerves grow very slowly. But then there's no pathway to grow. So what happens is it starts making a tuft at the end of the place that it is destroyed. It never finds the path to grow down. So that's the most worst type of injuries in upper brachial plexus injuries. So that is level 4 in Sunderland classification, 5 in Sunderland classification. So clinical subtypes, there is another classification called Narcos Classification, which is very clinically oriented. It looks at I told you the trunk level is the most important. So these slides, I am grateful for these few slides. It's from Dr. Amila Shashankaratnayaka, who is the plastic surgeon I work with for these brachial plexus injuries. So these are these are slides from a program he had with some Indian surgeons. So these are nice pictures of the Narcos classification. So as you can see, when the upper trunk C5 and C6 roots are gone, that is the typical Ernst palsy. You get the hand and wrist is still functional because you can flex. The child can flex the fingers, extend the wrist, but abduction of the shoulder, flexion of the elbow is gone. But the finger and wrist movements are beautifully intact. That's called Narcos type 1. These children have 90% spontaneous recovery. So this is a small video that I have. Stop. It's not a very good quality video, but you can see the child is moving the fingers, extending the wrist, and very infrequent shoulder movements are also there. The elbow movements are also there. So there's still paralysis, but wrist extension, finger flexion, finger extension, and even elbow flexion is there. So that's the shoulder abduction is not there. So that's an Narcos 1 injury. So we move down to Narcos 2. Both upper and middle trunks are involved. Then the child lacks wrist and digital extension. Your fingers and wrist both are not extending. That is the typical waiter stick hand, and it has a poorer prognosis than Narcos 1. So this is a beautiful classification. It not only gives you an idea of what roots are involved, what trunks are involved, but it also gives you an indication about the prognosis. So if you look at this video, this child can extend the fingers but not the wrist. Ignore his splint. He's not doing the wrist extension, but he's doing the finger extension. You can see it again. He beautifully extends the fingers, but not the wrist. There you go. Yeah. Typical. So this is the typical waiter stick hand we are talking about. So we moved down to Narcos 3. In Narcos 3, all three trunks are gone. Upper, middle, and lower. Your C5, C6, C7, C8, T1, all are gone. Everything is gone. Now there's a flail limb, right? So you can get a flail limb without Horner syndrome. How does the Horner syndrome occur? It involves the sympathetic trunk as well if there's Horner syndrome. But Narcos 3, it doesn't involve Horner syndrome. This is of bad prognosis. And Narcos 4 is this trunk is all the trunks are gone. Plus there's flail limb with Horner syndrome. This is the category of worst prognosis. So as you can see in this child, if you look at his left hand, there's nothing, not even finger movement. The whole arm is flail, and this is his face. Yeah, this is his face. I hope you can see the inophthalmos and the Horner syndrome, partial ptosis and inophthalmos. This is a closer picture. Partial ptosis and inophthalmos. This is a child who we saw recently. This is the worst type of injury. you can get in upper brachial plexus involved. These are not avulsion injuries, but the trunk injuries. But the worst type of prognosis. I have seen only about 4 of such children. It's rare. Mostly we see the upper plexus, that is Narcos 1 or 2. So, talking further about mechanisms of injury, roots of 5 and 6 are most vulnerable to traction injury because they are vertically oriented. Point of maximum vulnerability is called Erb's point at the commencement of trunks. That's where it commonly breaks. Mostly postganglionic, while there's subdural sheath preventing avulsion there, and may affect the suprascapular nerve. Even can affect the suprascapular nerve. So signs of bad prognosis again are Horner syndrome, ptosis, meiosis, anhidrosis on initial examination, and then these children with Narcos 3 and especially 4 can be affected with phrenic nerve injury, phrenic nerve palsy, which is which you can do an X-ray. And this child who has Horner syndrome, we did a chest X-ray to see whether there was an elevated hemidiaphragm. Luckily, he didn't have that. So, phrenic nerve palsy can also be associated with bad Narcos 4 injuries. You can see that on X-ray or ultrasound scan. Flaccid paralysis of the whole upper limb, we call it, also can call it pan-plexus injury. Yeah. So long-term sequelae of incomplete neurological recovery, especially the Narcos 3 and 4 and sometimes 2 also. So they don't fully recover. So what are the long-term sequelae? Your muscle imbalance. So muscles around the shoulder, around the elbow and the wrist, they get imbalanced. So you need muscle balance for the limb to grow and work in the normal manner. So you get muscle imbalance and internal rotation eventually. Internal rotation of the shoulder. I'm sorry, you didn't hear a few of my slides. Yeah. Sorry about that. Small technical problem, I think. My connection got lost. So we are back. I think you lost a few slides, so missed a few slides. So I think you saw this, perhaps. Uh, yeah. Horner syndrome, Phrenic palsy, and flaccid paralysis of the whole upper limb are bad prognostic signs. And long-term sequelae is you develop muscle imbalance and internal rotation contracture and glenohumeral dysplasia, elbow flexion contracture, and decreased forearm supination and wrist deformities can occur. And glenohumeral dysplasia is the dysplasia of shoulder joint. It may occur as early as 3 months. It typically happens like retroversion of the glenoid. Your glenoid cavity turns backwards, and the humeral head does not develop in the manner it should be. So it becomes shallow. The end result is uh, posterior subluxation of the shoulder can occur, and the majority develop internal rotation contractures, the typical contracture, and they will reach the hand like this, reach the mouth like this. It's difficult hand to mouth. They usually develop this movement, and they find it difficult to reach the back of the head. They won't be able to reach the back of the head with this glenohumeral dysplasia when that sets in. So evaluation is physical examination is the primary diagnostic tool. You don't need sophisticated investigations to diagnose brachial plexus injuries. You don't need EMGs. You don't need uh, anything much. You just do your physical examination. Uh, Careful evaluation of each major muscle group will help to establish the pattern of injury and even the classification. So you should know your root values. Your shoulder abduction is done by deltoid C5 and elbow flexion by C6 and elbow and wrist extension, triceps and common extensors C7. If you don't have your wrist extension, you know that your C7 is gone. Finger flexion by flexibility uh, profundus by C8. So serial examinations are needed to assess recovery because it's a very dynamic situation. So then you look for ipsilateral ptosis or meiosis on your examination because that will help you to differentiate between a Narcos 3 and 4. So investigations, you have to know why you are doing investigations. It's simple upper brachial plexus injury. You don't even have to do any investigations. Just watch for recovery. But when you have a bad injury, you tend to take an X-ray. What to look for is fracture clavicle or fracture humerus can be there. So if sometimes even if you don't have a brachial plexus injury, if your child's clavicle is fractured or the humerus is fractured, the children without a brachial plexus injury, they will keep the hand without moving. That is called the pseudo paralysis of the upper limb, and you can make sure that there are fractures with an X-ray. And another thing that you're going to see is elevated hemidiaphragm. Uh, that happens with the involvement of ring nerve. In injuries, Narcos 4 injuries, you definitely have to do an X-ray and see. So EMG has a limited indication in clinical practice. You don't need an EMG to diagnose a brachial plexus injury. Uh, when I talk to my surgical colleagues, they say EMG that we have regularly will not help. If at all, you need EMGs to find information prior to surgery, but the EMGs that we use are not sensitive enough to pick up useful information for the surgeons. So routine EMG is of no use. Surgeons will order that if they need. So ultrasound scan at 6 months is recommended in all infants with incomplete recovery to detect glenohumeral subluxation or dislocation. Even in that, the radiologist who is doing that should be used to doing such ultrasounds and should know what to look for and how to report it to the surgical colleague. So in LRH, we have had discussions with the radiologists there, and they know what to look for when we are ordering an ultrasound scan at 6 months in a brachial plexus injury. CT or MRI has no value as part of routine evaluation, but they could be very useful for the surgeons in preoperative planning. So, as I am a rehab person, I'm a rheumatologist and a rehab doctor, so I don't need many investigations. And even if I do an MRI, I don't know how to make use of it. So, the investigation I will do perhaps an X-ray and the ultrasound scan at 6 months. Uh, when you have referred children to the surgeon by that time, so the surgeon will also can also order that. So yes, management. So this is very important. uh, you need to talk and explain to the shell shock parents and explain the condition, because you can explain it, you can calm down the parents, you can explain if you after you examine if it is majority of these injuries are of Narcos type 1 or upper plexus injuries. Most of these injuries do recover. Only 10% injuries are the worst type of injuries, and up to 30% have some residual neurological problems. But about 70 to 90% they recover uh, with minimal or no sequel. So you can explain that to the parents after examining, after classifying that according to the Narcos classification. So you can explain. Then uh, balance of protecting the plexus. When there is a neonate, I would like to see these neonates in days old. So I get referrals from Castle Hospital and the DMH. So when that happens, we can explain to the parents. So there's this period of balance of protecting the plexus from further damage while preventing joint and muscle stiffness during early infancy. In the earliest period, what this is a very important message for all the people who are involved in brachial plexus injuries, the neonatologists, the pediatricians, and the therapists all around the country, because um, sometimes we see conversion of Narcos type 1 injuries to worse grades of they get worse if you malhandle these patients in their early days. First first 4 weeks, first 3 to 4 weeks of their lives are very important. You should know how to protect. So your management is uh, a balance of protecting the plexus from further damage while preventing joint and muscle stiffness during that time. So when these children present, you have to educate them how to protect the plexus. My occupational therapy colleague will help you to understand that. Then serial examination and referral for surgical management with careful patient selection and timing is of utmost importance. Then after the initial period, you don't have to even refer to the therapist. if you know how to advise to protect the plexus. There are positions that you can keep the neonatal little one's arm. So one way is to keep it across the chest, place it across the chest when supine, or on the tummy, and along the side of the body on supine, palm upwards. So those are the three positions that you can use at that time. Very important to know. Don't do any abduction because that can further injure. Don't take it anywhere beyond the shoulder level. Even don't bring it to shoulder level. Just lay it parallel to the body, palm turned upwards when the child is sleeping supine. Or you can keep it across the body, uh, hand touching the other shoulder, opposite shoulder. So those are the only positions only resting positions that you can do in the first 3 to 4 weeks time. So that helps to recover the injury if it is simple upper trunk injury. So when you see these children, you don't stop there, and you advise on handling. So you have to advise the mother when you feed, when you give a bath, when you dress. Uh, you have to do it in such a manner that you are not injuring the plexus further. So I am advising them not to put on any fancy dresses, even if you are taking the child to the temple, the Kovil, or the church. Not puffed up sleeves, but put on a very simple dress, the type you put on and tie at the back. Don't worry about tying, but start dressing with the affected side so that you don't disturb the arm. Just move the dress up the arm and use the opposite arm to adjust and put the other armpit. So that's how you do it. And on removing also, you remove from the good side and bring it all the way down the affected arm without uh, disturbing the position. So when bathing, picking up at all times, you need to protect the plexus. So then you do that, and then you uh, get the child down in a 2 week interval or so. So serial examination, and you are looking for signs of recovery from the beginning. The child may be having Narcos 2 level of injury might be showing, but then in serial examination she might start recovering. So serial examination, and you should look for signs of recovery and make a decision to refer for surgery with careful patient selection. So, positioning and handling, I already talked about this. Physiotherapy, occupational therapy, depending on who is available. I know at many places in the periphery, there's only a physiotherapist due to the lack of numbers of OT. If you have an OT, it's an upper limb injury, you can refer for OT. If not, even a physio would do. But then they should uh, be aware how to manage the cases. Both physios and OTs should know. So, and there's a place for Botox, and this is mostly after uh, referral for the surgeon when the residual damages are there. There, mostly my surgical colleagues decide when to give Botox. So then comes surgical management. There are twofold: re-innovation procedures and delayed secondary procedures. So positioning and handling, protecting the plexus while feeding, dressing, and bathing as I spoke. Infant's head and neck and the arm supported and moved as one unit without letting the floppy arm to fall. Dressing up should begin with the affected side and undressing with the good side, causing minimal disturbance to the shoulder. Dressers should be kept simple and easy to wear. Positioning, this is at birth, around very early period. These are the positions that I described to you already. Supine with upper limb close to trunk, back of the hand in contact with the bed, or palm up. Supine with hands placed over the opposite shoulder. So OT and PT further described. So range of movement exercises should be deferred, should be delayed by 3 to 4 weeks. Should be done with the baby's routine, like every nappy change and birth. Once when you start it, you have to incorporate it with the baby's routine, like every nappy change and birth. This is usually done in both arms simultaneously to stabilize the trunk and the scapulae. Mothers can be taught these simple strategies. Once when the initial period is gone, there's another position that you can use. It's like you are under a rest position, like this. You put both arms up uh, and abducted at the shoulder, flex to 90 degrees at the elbow, and place the child supine. So that uh, that position you can achieve only after the initial period has passed, and then you can place the arm palm up like this also after the initial period. So first 3 to 4 weeks you don't even do this. So passive exercises slowly should be replaced by active exercises with growth and recovery. When the child is rolling, you guide the arm. And what you should avoid is vigorous passive range of motion exercises causing bleeding and subsequent soft tissue scarring that should be avoided. So my surgical colleagues have told me that they have during surgeries they have seen scar tissues. That happens when we try to examine and move these kids when they have not been mobilized by the proper time uh, with the proper guidance. Sometimes they develop contractures, and then the later parents or therapists they try to move the arm vigorously, bringing it to the full range of abduction and so on. That can cause bleeding inside, so that those things are actually happening. So please be aware that you shouldn't do it. Instead you can slowly introduce these rest positions and start gentle range of movements exercises. As I say in this first row, first sentence, range of motion exercises should be deferred by 3 to 4 weeks. Then you start gentle range. When you do that at the proper time, contractures don't, they get minimized. So gentle tactile stimulation can be commenced from birth. Even from birth, you can start touching the arm, stimulating that to prevent neglect. This helps to prevent neglect. It can be combined with guided play and positioning as the baby grows. Guided guided play. As I said, when the baby rolls, you can guide the arm. You can parents can look at the good arm and copy the way that it follows uh, in unrolling and weight bearing on that arm. So my therapist will describe how to do these things. Electrical simulation has not shown to improve the long-term outcome, but constraint-induced therapy can be useful. There is some evidence for constraint-induced therapy, and splints also have a place. So this is a child. This I wanted to show this when we advise the parents. Some people tell to tie the baby's arm, place it on the tummy, and tie it with a nappy to keep it in place. Uh, when that happens, the parents don't know until what period you have to do this. They come even when the child has developed movements. They come tying the arm tight on the belly. So you have to be careful on what we advise and do serial examinations and keep a close follow up. I usually follow them up every 2 weeks in the initial period. So Botox, the place of Botox, there is a definite place of Botox here. It is used an adjunct to non-surgical and surgical treatment. It, limited and inconclusive evidence, but it can be useful in instances where you get uh, difficulties in elbow flexion, where you can it is usually given to the antagonistic muscles to weaken the antagonist to get the agonist action. So may be useful to overcome co-contraction of triceps in the presence of limited active elbow flexion. That's where mostly we use Botox. So surgical management. So recent advances in microsurgical techniques. Uh, there are the earlier surgical treatment was considered futile because they are very cumbersome, long surgeries. Plastic surgeons generally they don't like to do these surgeries, day-long surgeries. Um, the there are re-innovation I'm talking about. So even if you do the surgeries, there can be incomplete recovery. Uh, so basically of two faults, it's re-innovation surgeries and delayed secondary procedures. These should always be, a plastic surgeon cannot work alone. They have to always forget the best results. They should always be complemented by carefully planned therapy. So our plastic surgeon works with his occupational therapist. So surgical procedures again. I am not the best one to talk about these things. I just have a very superficial knowledge about surgery. So now, reinnovation surgeries are of nerve grafting and nerve transfer should be done early. This is very important for me. They should be done early, so I should know when to refer for surgery. So should be done early before more templates and deinnervated muscles degenerate. This is this is neurotization surgeries, nerve grafting and nerve transfer. Obviously, these are for Narcos type 3 and 4 injuries. So I should all the clinicians who work in rehab services, the neonatologists should know when to refer and how to identify children to refer for surgery. So that is my part of the lecture. So it's usually done. These surgeries are usually done between 3 to 8 months of life. So before that, we need to identify these children and refer. Recovery of elbow flexion following surgery can take another 3 to 9 months. So elbow flexion is a big landmark in these injuries. So secondary procedures are like muscle transfer, tendon transfer, and so on. So indications are persistent internal rotation contracture, progressive glenohumeral deformity, infantile dislocation. So we talked of posterior subluxation, so they can dislocate, and inadequate shoulder abduction and external rotation. The procedures that can be done are anterior capsular release, tendon transfers, osteotomy and derotation, and glenohumeral remodeling. So if you do the osteotomies, the plastic surgeons might get help of the orthopedic surgeons also. So indications and timing of surgery is very important for people like us. Surgery considered if no return of anti-gravity elbow flexion by 3 months. So even if you are a referring doctor, if you forget everything about this lecture, you have to remember this thing. Anti-gravity elbow flexion is not returning by 3 months, you should refer the kids to surgeons. I'm not waiting until 3 months. I'm referring them at 2 months. So there is ongoing debate about the accurate identification of kids who need surgery versus conservative management. So even if we refer, the plastic surgeons are watching. They are not doing immediate surgery. So few of the cases that you refer might not undergo surgery, but timely referral is your duty. So no strong evidence base to support microsurgical procedures again. So general consensus are surgery at 3 months, Narcos 3 and 4 as I said. Narcos 4 with elbow flexion but no recovery of forearm and hand function. No consensus in Narcos 1 and 2. Narcos 1 and 2 are not very severe injuries. Most of the time they recover on their own. So there are no consensus in microsurgical repair, very early repair in these injuries. So 3 and 4, yes, because they have got flail arm. If you don't do it, nothing will return because there's bad injury, probably axonotemesis, neurotemesis, that type of injuries. So they are not recovering on their own. So this is to show you. This is a little older child. This is to show you how children evolve when they get older. Uh, Sorry. So he can readily supine stand. There's no big
Yeah, yeah, little
contractions
bit.
there,
Yeah, madam.
even though he at rest he takes it. That is called eye cover test, which I have learned from my plastic surgeon colleague, Dr. Amila. So you do that to encourage the arm movement. If you can see, he still has no uh, wrist extension. Fingers are extending a bit, but not to the fullest. He has definitely no wrist extension, but he bends the elbow. So uh, bends the elbow, but it's not directly anti-gravity. This child is 4 months old. I have already referred this child to the uh, surgeon.
Yes.
So now it's time for range of movement exercises. I'm just trying to see whether the child reaches the full range of movement. So, and that is the way you do the exercises. Bilateral, you do it for both sides to keep the symmetry. So this child has a little leg. He will have difficulty reaching the mouth, reaching the back of the head. So shoulder dystocia can occur early. So that is how you do the gentle range of motion. I'm not the one to show this. This my occupational therapy colleague or therapy colleague should show, right? I'm just trying to get whether there's a limitation on the range. Okay. Uh, so the take-home messages are, it's very important to take these take-home messages because if I can share you a little story, uh, not to find fault or to blame anybody. One day I got a call from one of my junior colleagues, my students, actually postgraduate students, that he has a brachial flex injury in his hospital in the periphery where he works. So I told him, why are you telling me? I have shown you and taught you how to do it. So if you think that conservative management is not possible, you refer to a good plastic surgeon. So then he was telling me, Madam, there's an interesting story. You should listen to that. I'm sending these people to you. So these people came, and I could see that there's a very flail arm. It was like the child did not have Horner syndrome. It was a flail arm, no finger movements, and it's an Narcos 3 injury. So then the parents were, telling me stories. They were telling me that initially the child could cling on to the mother's finger, and they kept the child for 2 days with them, and then the child was taken to the PBU for some other complication, jaundice or something. So before he was taken into the PBU, uh, the child could, you know, uh, he was flexing the fingers and touching mother's fingers. Uh, when they got the baby back, that was gone. That ability was not there. The arm was just hanging flail. So that tells us that something went wrong during that PBU stay, or even the parents could have caused it. So people who were managing the child were not aware that you could make the plexus injury worse. So this is my first take home message to you all. Let it be a therapist or a doctor, what neonatologist, a pediatrician, or a trainee, or a therapy student. It's very important to prevent further plexus injury and allow it to heal in the first 3 weeks of life. Everybody should know how to protect the plexus, right? So So that's my first take home message. It's a very important message. So I remember how I advised the mothers to keep, there are 3 positions to keep the hand across the tummy, across the body towards the opposite shoulder, along the body, palm upright. Don't put it in any other positions. While handling, bathing, dressing, you protect the arm without making it drop, or don't cause separation of the moving away the neck and the shoulder. So that's the first take home message. You have to do serial evaluation and introduction of appropriate OT and PT at the appropriate times. Usually it's in 4 weeks or even 6 weeks. We can refer to the therapy even before. You can refer before that if you have a very good OT and PT, where they know what to do with these children. Otherwise, don't refer. You keep them, advise them how to keep the plexus protected. So third one is identification of kids who are not going to recover, and timely referral for surgical management is crucial for better outcome. Timely referral. So single most important prognostic sign in recovery is anti-gravity elbow flexion. So your shoulder should move against gravity, and surgical referral should be done at 2 months. My cutoff is 2 months. I don't wait for 3 months if no anti-gravity elbow flexion is occurring. So if you take these a few take-home messages, I think my talk would have been useful. These are my references. I deeply acknowledge these 2 people, Dr. Neha Gunapalaka, consultant rheumatologist. This is my teacher in everything I know in pediatric rehabilitation, and Dr. Amila Shashankaratnayaka, my colleague, plastic surgeon, consultant plastic surgeon. Now is working in teaching hospital Candy and having a session in Bellary. So with that, I will hand over to Ms. Veronica Lapmani, occupational therapist. Thank you.
Thank you very much, madam. I am Veronica Lakmari, occupational therapist at Lady Ridgeway Hospital. Now I am going to share my knowledge regarding the occupational therapy intervention for the neonatal brachial plexus injury. First, we have to consider about the anatomy of the brachial plexus. Our madam explained the anatomy, so I'm not going to explain it again. Then we move to the definition. What is a brachial plexus injury? The brachial plexus injury is an injury to the network of the nerves that send signals from the spine to the shoulder, arm, and hand. This injury occurs when these nerves are stretched or, in the most serious cases, torn. This is usually happen when the shoulder is pressed down forcefully while the head is pushed up away from that shoulder. Neurological types. There are main 3 neurological types. The first one is neurophrexia. This is happen due to stretching of the nerve. The recovery is usually complete with no residual symptoms. The second one is axonotmesis. This happens due to disruption of nerve fibers with intact sheath. The recovery is variable but never complete. This will have some functional limitations. The last one is neurotmesis. This happens due to disruption of both the nerve axons and their surrounding sheath. This has the worst prognosis. Then we move to the pathological types. The first one is Erb's palsy. The Erb's palsy is the most common type among the brachial plexus injuries. In there, the upper trunk of the brachial plexus is damaged. Then the total palsy. In here, all the root of the brachial plexus are damaged. The limbs are totally flaccid. They cause the deformities in forearm and hand. The last one is Klumpke's palsy. This is due to the damage of the lower trunk of the brachial plexus. Mainly the hand functions are affected. Erb's palsy. Erb's palsy is the most common type of the brachial plexus injury. Nerve palsy of the upper trunk, C5, C6 of the brachial plexus that occurs during labor. Then we move to the clinical presentation. In the clinical presentation, as shown is in this picture, we can see this affected arm of this child. The shoulder is abducted and internally rotated. The elbow is extended and pronated. The wrist is in the flex position. If a child is having following features, we can suspect that there is a brachial plexus injury. If the child is not using the hand or neglect the hand, absence of the thumb sucking, if the grip is weak or keep the hand in odd positions, we can suspect that there is a brachial plexus injury in his limb. If the newborn will keep the limb in waiter stiff position, we considered the child has a brachial plexus injury, as well as the Moro's reflexes are asymmetrical. Then the clinical examinations. If it is a surgery needed, the following tests can be done. There are EMGs, nerve conduction studies, MRIs, and CTs. The prognosis. The majority of infants with brachial plexus injury, 80% to 90%, recover in the first month to 6 weeks of life. Children who continue to have problems beyond 6 weeks should be seen by the plastic surgeon. Then the assessment. This is a very important part of our occupational therapy intervention. We use the modified mallet classification for assess the child with brachial plexus injury. When we consider about the abduction, if there is no abduction, we consider it as grade 1. If the abduction is more than 30 degrees, it is considered as a grade 2. The abduction is in between 30 to 90 degrees, it is grade 3. Over 90 degrees, it is grade 4. If the child has abduction in the normal range, we consider it as grade 5. We assess using this modified mallet classification, the external rotation, the internal rotation, hand to neck, hand to spine, and the hand to mouth. The major problems. If there is no proper therapy program, the following problems may occur. The main problem is the contractures. If we are not commence the therapies in the early stage, the contractures can be occurred. The internal rotation contractures of the shoulder, flexion contractures of the elbow, supination and pronation contractures of the forearms, as well as the ulnar deviation of the wrist. Sometimes the wrist drop can occur. And also MCP IP joint extension, weak or absent in flexion digits, and the instability of the thumb. Aims of the occupational therapy. There are main 4 aims. The first one is parental education. Then to increase the awareness of the affected arm. Third one is to encourage the baby to move his arm. The last one is to prevent stiffness of the joints of the affected arm. Then the management. We can divide the management into main 2 parts. First one is pre-operative management and the post-operative management. In pre-operative management, we considered before the surgery. In the post-operative management, the management after the surgeries. The 2 management are different in very little amount. Occupational therapy intervention. In the occupational therapy intervention, parent education is the intervention. In here, this is very important to educate the parent regarding the condition as well as the prognosis and the occupational therapy program. And also we should educate the other family members to get their help for the therapy intervention. Second one is prevent neglection of affected site. If the child is neglect his affected site, it is very difficult to get improvements. So we have to reach to the baby in his affected site, and also we can talk to the baby in his affected site, and we can place toys and we can play with the baby using his affected site. In here, we can use toys with sounds and toys with lights. So we can get attention of the child by using these kind of toys and encourage his movements. The third one is the safe handling and positioning. In here, in the first 3 weeks, it's very important to immobilize the affected arm. So we have to use correct handling and positioning techniques. When the child is on the mother's lap or in the mother's hand or in a cot, we should care about his affected hand. When we are positioning the child, we can use some pillows. For example, trouser pillows we can use for that. Giving the support to the shoulder is important to prevent further damage. If it is needed, we can apply some splints. For example, we can apply some splints to prevent the wrist drop. In the handling and carrying positioning, we should care about the affected arm in feeding, bathing, dressing, and other activities throughout the day. The next one is maintain joint range of motion. We can use active assisted exercises, bimanual activities, and play activities to maintain the joint range of motion, as well as the as well as improve the joint range of motion. It is very important to prevent the stiffness of the joint. The very important thing is we should start this mobilization after 3 to 4 weeks of life. Next one is bimanual activities. In bimanual activities, we can use them to encourage the child to use their affected hand in play. These are very interesting activities, so we can engage the child in those types of activities. The sixth one is play activities. As occupational therapists, we can create different types of play activities. According to the child's impairment, we can decide our activity program. And also we can use our findings of the mallet score to plan these activities. Splinting. We use splintings for various purposes. For positioning the hand, to prevent contractures, and to prevent further damage. In the preoperative and the postoperative management, we use splints for immobilize the hand, as well as we use splints to facilitate the activities. In this picture, you can see we use elbow cutter to facilitate the shoulder abduction activity. In these pictures, you can see we applied some splints to prevent further contractures, further damages, and facilitate the activities. Next one is strengthening activities. We use the strengthening activities for strengthen the affected muscle groups. In here, we can use the pushing and pulling activities as well as the lifting heavy toys. Then we move to the weight bearing activities. The weight bearing activities help to improve the strengthening of the shoulder girdle muscles. We can use them to avoid flexion deformities of upper limbs. As shown in these pictures, the child is bearing the weight on his hand as well as the forearm. The last one is recreational therapy. In the recreational therapy, we can encourage a child to use the hand in these types of activities. For example, swimming, dancing, and some sports. So we can improve the joint ranges and use of the affected hand for activities. The post-operative management. As I mentioned in the previous slides, the post-operative management is very important part of our therapy intervention. So we have to continue our therapy intervention after the surgeries also. So we have to mobilize the hand. We can use splintings. We can do play activities as we done in previous. So if it is needed, we have to do scar management. Then we should encourage the child to return to the play after the surgeries. This is very important message. Action and early intervention is lead to better prognosis. In the first 3 weeks, this is very important to keep in the mind to immobilize the hand and use the correct handling and positioning techniques. If there is no improvement, we should refer to a plastic surgeon for further management. Thank you very much.
Thank you, Veronica, for most illustrious explanation of occupational therapy management. We come to the end of another episode of discussion around the topics, a very important topic of brachial plexus injury done by SLFUD. I think we can come to the end of the session now. Okay.